would like to welcome the arrival of young Berusaha Professor Engineer Dr. Dimyati, Deputy Vice Chancellor of Research and Innovation, accompanied by Professor Dr. Siew Pauline, Professor in Clinical Pharmacy from the Department of Primary Care Medicine, Faculty of Medicine, University Malaya. Thank you, everyone. Please take your seats. Kepekan Kuala membeli bingka, mawar mekar membawa lebah. Majlis bermula, tirai dibuka dengan alunan madah yang indah. Selamat datang ke Syarahan Perdana Profesor Dr. Siew Pauline pada hari yang berbahagia ini. Dengan izin hadirin sekalian, majlis ini akan saya teruskan dalam bahasa Inggeris. Ladies and gentlemen, I'd like to extend our warmest welcome to our esteemed guests. Yang Berusaha Professor Engineer Dr. Dimyati, Deputy Vice Chancellor of Research and Innovation, University Malaya. Yang Berusaha Professor Dr. Siew Pauline, Professor in Clinical Pharmacy, Department of Primary Care Medicine, Faculty of Medicine. Yang Berusaha Professor Dr. Yvonne Lim Ai Lian, Associate Deputy Vice Chancellor of Academic and International, University Malaya. Yang berbahagia, Profesor Datuk Dr. Yang Farida Abdul Aziz, Dean of the Faculty of Medicine. Yang berbahagia, Tan Sri Professor Emeritus Datuk Dr. Muhammad Amin Jalaluddin, Professor of Otorhinolaryngology in Faculty of Medicine and former Vice Chancellor of University Malaya. Management of Faculty of Medicine and University Malaya Medical Center, distinguished guests, professors, doctors, ladies and gentlemen, boys and girls, who are joining the inaugural lecture virtually and physically today to this very special event hosted by the Faculty of Medicine, University Malaya. I'm Dr. Christine Shamala Selvaraj, and I am honored to be the Master of Ceremonies for the inaugural lecture of my inspiring and buzzworthy lecturer and colleague, Professor Dr. Siew Pauline. Ladies and gentlemen, I'd like to invite Dr. Jazlan Jamaluddin to lead in the Dua recital.
Alhamdulillah Rabbil Alamin. Wassalatu wassalamu ala ashrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. All praise be to Allah. Peace and blessing be upon Prophet Muhammad sallallahu alaihi wasallam, his family and his companions. Allahumma ya Rahman ya Rahim. All praise be to Allah for granting us the chance to assemble today for the inaugural lecture of Professor Dr. Siew Pauline. We pray for your blessing to ensure that this ceremony runs smoothly and successfully. Ya Allah, we gather here today to express our gratitude, asking for your help and guidance. Grant us strength and courage to find and gain valuable knowledge that will benefit the mankind. Bestow upon us blessings, physical and spiritual health, and peace of mind. Guide our team at University Malaya to greatness, peace, and prosperity. Grant strength to our teachers and leaders as they continue to serve the people, society, and nation. Allah, Ya Karim, Ya Alim, make our country a land of blessing and favor with everlasting peace. Please bless us with your tawfiq and hidayah. Forgive our wrongdoing, bestow patience upon us to face all challenges, and please accept our deed. Sallallahu ala Sayyidina Muhammadin Nabiyyin Karim wa ala alihi wa sahbihi ajma'in walhamdulillah.
Thank you very much, Dr. Jazlan. The professor's inaugural lecture is one of University Malaya's most cherished and revered traditions. This lecture honors the professional journeys taken by our professors and provides an opportunity for them to share their wisdom, inspirations, and philosophies with us. We are grateful to be here today as an audience for the inaugural lecture by Professor Dr. Siew Pauline, or Prof. Pauline, as she is better known to many of us, a dedicated and passionate professor at the Department of Primary Care Medicine, and someone who has had a long and illustrious career with University Malaya. Nature often serves as a profound teacher, demonstrating various systems and models that inspire efficient human behavior and cooperation. This inaugural lecture explores the power of the beehive, an extraordinary example of organized and goal-oriented teamwork. And this is not the kind of bog hive where resistance is futile and all minds within operate as one collective. The Star Trek fans will know what I'm referring to. This is a beehive that operates through the seamless collaboration of thousands of bees, each with its own defined role contributing to the colony's success. Today, Professor Dr. Pauline will be sharing her journey within the hive in this inaugural lecture entitled Hive Power, Interprofessional Collaboration to Improve Elderly Health Care. Without any further ado, I would like to invite Yang Berusaha Professor Engineer Dr. Kaharuddin Dimyati, Deputy Vice Chancellor of Research and Innovation, University Malaya, to chair the lecture and to subsequently introduce Professor Dr. Siew Pauline. Please welcome Professor Dr. Kaharuddin.
Assalamualaikum warahmatullahi wabarakatuh and very good afternoon. Thank you very much, MC. Today I saw a piano. I think whoever came to the last series of inaugural lecture, there are also some yeah. Okay. All right. Thank you very much again, MC. Yang berusaha Profesor Dr. Siew, Pauline, Professor in Clinical Pharmacy, Department of Primary Care Medicine, Faculty of Medicine. Yang berusaha Profesor Dr. Yvonne Lim Island, Associate Deputy Vice Chancellor, Academic and International. Yang berusaha Profesor, yang berbahagia Profesor Datuk Dr. Yang Faridah Abdul Aziz, Dean Faculty of Medicine. Yang berbahagia Tan Sri Profesor Emeritus Datuk Dr. Muhammad Amin Jalaluddin, Professor of Otorinolaryngology, Faculty of Medicine, and also former Vice Chancellor. Management of Faculty Medicine and University Malaya Medical Center, distinguished guests, professors, doctors, ladies and gentlemen. It is my honor indeed to introduce today's inaugural lecture, Professor Dr. Siew, Pauline, a Professor of Clinical Pharmacy from the Department of Primary Care Medicine, Faculty of Medicine, University Malaya. Professor Pauline began her journey in education at Asunta Primary and Secondary School in PJ, very nearby to UM. Before pursuing her pharmacy degree at Victorian College of Pharmacy in Medicine, now Monash University. Yeah. At just 22, she was already registered pharmacist. What an achievement. In both Australia and Malaysia. Her early career was marked by courage and compassion, leaving her job at University Hospital to become a bone marrow donor for her sister. After returning to Malaysia in 1995, she resumed her work at University Hospital and played a key role in establishing the sterile, complex, and cytotoxic drug reconstitution services at UMMC. In 2000, she initiated the Drug Information Center, and by 2008, she led the pharmacy's digital transformation, including the implementations of e-prescribing. While working full-time, she pursued a master's in medical science, which was later converted to a PhD. She obtained her doctorate in 2010, marking the beginning of her academic career at University Malaya. Today, Professor Pauline heads the research committee in her department, mentoring staff, leading research initiatives, and supervising over 35 postgraduate students to completion. Her research in implementation science focuses on improving patient outcomes, shared decision-making, and enhancing healthcare delivery through evidence-based practices. A passionate educator, she is known to her creative teaching methods such as using jigsaw techniques and the Jeopardy game to train future healthcare professionals. Beyond academia, Professor Pauline is also an accomplished golfer. Wow. Last year I did not see you. You were there? Eh? Oh, okay. Then my mistake then. Okay, so this coming August? All right. Okay, representing UM in the UM NUS Golf Tournament since 2002. Wow. And currently serving as the team vice captain. Internationally, she sits on the International Pharmaceutical Federation's Technology Advisory Group and has been invited to speak in Sri Lanka, Indonesia, and Australia on the use of AI in pharmacy. She also co-chairs the Malaysian Pharmaceutical Society Health Technology, Devices and Innovation chapter, and continue to champion collaboration, research, and innovation in pharmacy. Professor Pauline embodies dedications, resilience, and leadership. Her unwavering commitment to nurturing the next generation of pharmacists and researchers is truly inspiring. Congratulations, Prof. With that, ladies and gentlemen, please join me in welcoming Professor Dr. Lai Siew Pauline to deliver her inaugural lecture entitled Hive Power Interprofessional Collaborations to Improve Elderly Healthcare. With that, over to you, Prof.
Thank you, Prof. Kaha, for the kind introduction. Now I've got to put my specs on to look learned. Thank you all for coming here today. On 16 July 1969, I was born in University Hospital. To my parents, Sir Richard Lai and Matron Lai. Both my parents were nurses. My father was conferred the title Sir by John Paul II for his international work with Catholic nurses around the world. And my mother, Matron Lai, was one of the pioneer nurses for University Hospital. She basically started the hospital as a nurse, and that was why I was born here. And for a while, when the both of us were working here, I was never known as Pauline. I was known as Matron Lai's daughter. I did my primary and secondary school in Asunta, and I have some of my Asuntarian friends here, whom I've known since 7 years old, and they're my lifelong friends. I did my South Australian matriculation at Taylor's College, got accepted into pharmacy, and graduated with a Bachelor of Pharmacy in 1990. I did my student hours in a country hospital in Traralgon, and why country was because I didn't know how to speak when I went to Australia, and in the interviews I would bumble, and all the Aussies had all the good jobs in Melbourne, and I had to go to the country, and that was when I learned how to speak. I then learned how to speak by the time I got my trainee, when I went for my trainee interview, and I got my position back in Melbourne at Mercy Hospital for Women. But, you know, the country friends that I made in Traralgon, they offered me hours to do training in a retail pharmacy, which I really liked, and I went back there for a while. So, as mentioned, I was a fully registered pharmacist at 22 years of age in Australia as well as in Malaysia. And the only reason why I mentioned that is because in Malaysia, the average age for a pharmacist to graduate and be fully registered is about 24, 25. So at 22, that is a really young and naive age. You think you know everything, but you don't. What do I do? With a pharmacy degree, you can actually work in retail, hospital, pharma, or academia. And when you don't know what you want to do, what do? You apply for everything. That's what I did, okay? At that time, there was only one pharmacy school in Malaysia, and that was USM. And they were only producing maybe about 100, 120 pharmacists a year. And it wasn't enough for the pharmacies, for the country's demand for pharmacists. So guess what? Every job that I applied to, I got it. The first people that actually offered me a job was Guardian Pharmacy, and it was in Bangsa Shopping Complex. And I thought, Bangsa Shopping Complex, oh, that's so groovy, that's so high class, you know? So I accepted it. And the day that I actually was due to attend work, to report for work, I actually had a very bad sore throat and fever. And so I called in sick to say that I'll come in maybe in about 2 or 3 days' time. But in that time that I was sick, guess what? I got a job offer from SGMC. So I never turned up for my job at Guardian Pharmacy. Oops, I hope there are no people from Guardian Pharmacy here. And And I went to SGMC and I reported for duty, and the chief pharmacist was just too busy to spend any time with me. She just said, "Hello, I'll talk to you later. Can you just sit at the dispensing counter in outpatient pharmacy and dispense? When I'm free, I'll come and talk to you." Now, for those of you who know me well, you will know that my Cantonese is never the best. I know how to order food, but my husband always says there's a chance that it might come out wrong. Sometimes it does. But within the morning session when I was dispensing medicines, I already committed my first dispensing error. Instead of saying take one tablet 3 times a day, I told the patient to take 3 tablets once a day. And the dispenser was sitting next to me, said, "Do you know what you just said?" I said, "What?" And I had to call the patient back, come back. What I told you was wrong. And I thought I did not study pharmacy 3 years, did my internship to actually dispense medicines the whole day. And within one day, I decided I was never coming back to SGMC because, guess what? I got the job offer. I was very naughty, I told you then. So Glaxo Malaysia offered me a job. And you know, Glaxo is a multinational company. You can get to travel the world, maybe in business class. You can get rich. The job prospect was to be a production pharmacist. And I thought, hey, production pharmacy is something new. And the pharmacists who were down there said, "Look, I'll mentor you and I'll teach you the ropes." And guess what? He was too busy again. Never taught me anything. He just said, "Read this stack of manuals." It was a code of good manufacturing practice. I spent days, weeks reading about machines, how the machines, which machines press what tablets. I had staff under me that were 40-year-old men, which I did not relate to. And I was supposedly to be their boss at 22 years of age. And machines I didn't relate to. Being a boss of people, especially guys who were so much older than me, I didn't relate to. So guess what? But I lasted on that job for 1 month. I tried. Okay. University Hospital finally offered me a job. And again, we were very short of pharmacists. And even being a new rookie, I was immediately put in charge of a section. And I had nice colleagues, I must say. And so I thought, this is good. I like what I do, and I had a chance to actually do something, change something. But academia really never crossed my mind. But troubled times loomed. My sister was diagnosed with chronic myeloid leukemia, and she was then in Melbourne seeking treatment. I was the only person who was close enough to be a donor to her. And I had only started work in University Hospital for less than a year. So I did not qualify for unrecorded leave, compassionate leave, nothing. I had to resign. And so I did because I had no choice. So I went down there to Australia for about 2 to 3 months. And by the time I came back to University Hospital, now as a contract worker. I lost all seniority. I did not have my permanent position anymore. But I thought, maybe, okay, that's fine. But dissatisfaction came in because I knew I was not getting anywhere with a contract position. And so I decided, okay, I'm a registered pharmacist in Australia. Why don't I go back to Australia, apply for my permanent residency? And I did. And I went back to Australia as a PR with the intention of migrating. And I actually got a job in Alfred Hospital. Now, having been a section head in University Hospital, being a run-of-the-mill pharmacist in Alfred Hospital was then now pretty boring. And guess what? Of course, I applied for another job. And this time, I actually got into GlaxoSmithKline, again Glaxo, but I knew then what I wanted, never again production pharmacist, but now it was more like a medical associate, which means there was a drug information pharmacist for one of the Glaxo products. And my product was Flixotide, fluticasone inhaler. I really enjoyed it. And I think I would have stayed on in Glaxo. I would have gone places with Glaxo in Australia. But again, life throws you a curveball. My mother was diagnosed with cancer. And it was during this time where I was having the so-called life in Australia. I was a permanent resident down there. My sister had already passed away by then. It didn't make sense that my mother was going to pass away. My father was going to be alone eventually in Malaysia, and I was going to be alone in Australia. So I made the decision to come back for good, and I did. And guess what? I came back to University Hospital, also still as contract. And this was obviously when my career started, because this is when I started settling down. Now, the reason why I told you all that is because it actually gives you an idea of the person that led me to the person that I became today. In the 1990s, pharmacy in Malaysia, clinical pharmacy, pharmaceutical care, and interprofessional collaboration was non-existent. This is the cough syrup. This is not the picture of the cough syrup that we had then. Okay? I remember in the early days, I saw a senior attendant pouring all the ingredients to make the cough syrup in a stainless steel barrel. He was doing it all by himself without any checks, and you should have seen the look of horror on my face. In Australia, it was ingrained to us. Every active ingredient has to be double-checked by a pharmacist so that there's no dispensing error in any extemporaneous preparation. And the UMMC hospital budget didn't allow us to buy nice cough syrups like this. We had to make it in bulk, homemade is cheaper. So I saw this attendant stirring this cough mixture all by himself, and he made it all. And when I checked with the senior pharmacist, I said, oh, he's been doing it for years. He knows the formula by heart. He doesn't even need to refer to the formula. My jaw dropped further. I remember going home to my mother and I said, we are not going to get any cough syrups from UMMC hospital pharmacy. If we are dying from a cough, we are going to a retail pharmacy to get it because I do not know what he puts in it. Today, rest assured, you can get the cough mixture from the UMMC pharmacy because we now buy it pre-packed like this, okay? So just to let you know that at that point of time, it wasn't. The second thing that I really noticed was that cytotoxic drugs, which are drugs used to treat cancer, were reconstituted in the ward by junior doctors, most of them housemen, in non-sterile conditions with no personal protective equipment. And again, my jaw dropped because as a trainee pharmacist in Australia, I was taught how to reconstitute cytotoxic drugs in a cytogard cabinet with full personal protective equipment, protecting me from the drug and protecting the drug from pathogens. So it was a total culture shock to me coming back from Australia, and pharmacy in Malaysia was 20 years behind Australia. So that led us to our dream. Mrs. Dillon and I, we had the dream of building a sterile complex to combat all the issues, and Mrs. Dillon is sitting right here, my partner in crime. We built the sterile complex, of course, with money that our hospital actually fought for, and that's Mr. Siew, our contractor. We went to Australia, we were trained there, again to refresh our memory. We came back and trained our pharmacists, and that's the sterile complex then when it was brand new. And so Mrs. Dillon was the pharmacist, she was the overall boss of the sterile complex. She always says, I'm boss because I'm bigger than you. Yes, you are, but she was also the most senior pharmacist. And so she became the boss of the non-cytotoxic section, and I became the boss of the cytotoxic section because it was a really huge space. Once that service stabilized, I then went on to set up the Drug Information Center. This was basically due to my knowledge and experience from Glaxo in Australia, and that's Amrahi, our chief pharmacist, then probably coming to boss me around, tell me what to do. And you have walked down that corridor that says Pusat Maklumat Ubat-Ubatan in the first floor of pharmacy. That's, I'm sure, a familiar sight. Having stabilized that, I then went on to computerize the UMMC pharmacy, which was in existence since 1968. It was a manual pharmacy. So to computerize it totally from a manual pharmacy that had, at that point of time, almost 11 million in budget for drugs was not an easy feat. And we finally managed to computerize the dispensing, ordering, and production, and eventually started off e-prescribing with clinical decision support. And the Department of Primary Care Medicine was one of the first departments to support us in this. And for that, I'm truly grateful for the Department of Primary Care Medicine. I eventually appealed to the management of UMMC and said, can you please consider switching my contract position to a permanent position? And, and I think the UMMC management maybe felt sorry for me. Okay, and so they agreed. And I then worked myself up to the senior management of the UMMC pharmacy department, and these were the senior pharmacists at the time. And somehow or other, Miss Lo Yok Lin, your photo is not here, but you were also part of it. And that was where I was. But you now know me, right? I got bored. I came to a point in my pharmacy career where whether I closed my eyes or opened my eyes, I went to work, I could do it. So it was no longer mentally stimulating. And you know what? Prof Amin at that point of time was pengarah, and he knew, I think he knew. Management was sending all these people for courses, and it was for a motivational camp. We called it the torture camp. And when we got this letter, all of us cringed because we knew we couldn't say no. And you know what? Behind every cloud, there's always a silver lining. I met my 2 torture inmates, Prof Chua Siew Siang and Prof Christina Tan. Okay? And you know, it's during this 1 week where you have nothing to do, you're in an enclosed place, and you're being tortured. So you tell each other your stories, and I'm telling them how I'm being bored and all that sort of thing. And this is where Prof Chua Siew Siang actually said, you're bored because you've got nothing to stimulate your mind. Go do your masters. I said, what's masters? Why should I do my masters? What's masters used for? She said, doesn't matter, you just do it. I think you might like it. And so I did. So I actually registered in as a postgrad student whilst working full-time. And because my topic was on osteoporosis, I then approached Prof. S.P. Chan, who was the osteoporosis guru at that time, registered in 2005 for a master's in medical science, enjoyed the research process very much. And that was when you need a supervisor like this, you know. Prof. Chua Siew Siang started disturbing me. Why don't you convert your master's degree to a PhD degree? Who? You can do that? I asked her. She said, yes. And suddenly I thought, oh wow. Suddenly the PhD degree sounded a little bit more exciting because guess what? I think I can be called a doctor after that. So I converted from master's to PhD, and Prof Amin was instrumental in this. And because of you, Prof Amin, you gave me the chance to convert. I graduated with a PhD in 2009. This was the topic of my thesis, and I actually did my PhD during the time when it was not compulsory to publish to graduate. The PhD students in this hall must be thinking, rats, I should have done my PhD then. Okay? But you know, guess what? I actually published 7 publications from my thesis, from my project, and I was a very good PhD student. I never questioned Prof. Chua when she said, write this as an abstract, write this as a paper. I just followed what she said. You know why I didn't argue with her? Because I was so busy working full-time. When she said, I just said, okay. And I came up with 8 abstracts and presented them in national and international conferences around the world. You knew this question was going to come next, right? What to do? But this time it wasn't me. It was Prof. Christina who started kacawing me. What are you going to do now that you got your PhD? You know, that'll be what she'll say, right? So she was then the head of MERDU, which is the Medical Education Research and Development Unit. She actually said, I need academic staff to come over. Can you come over to help me? And I said, if UMMC releases me with all my service intact and my pension intact, I'll come. And somehow things worked out. They did release me, and I came over, and I came over to MERDU. But guess what? I didn't like MERDU. I really tried. I really did try. But then somehow along the way, Prof. Ng Chek Jen, CJ, he wanted to build up primary care. He came up to me, I don't know whether he knew that I didn't like MERDU or not, but he actually said, why don't you come to primary care? I want to build it up. I want non-clinicians, non-family medicine specialists to come to our department to build the research component of primary care up. And so I did, with Prof. Adiba's blessing, which she was dean at the time, and that was how I ended up in primary care. Medicine, yes. And I was very much an accidental academician. I never planned this from the beginning to be an academic person, let alone a professor. Okay. So having been a pharmacist, hospital pharmacist for 20 years, it made me realize that pharmacists shouldn't be product-centric. We should be patient-centric. We should look into improving patient outcomes to help patients to improve their disease management, to empower them to monitor their own conditions, and to practice shared decision-making where the patients have a say in how they want to be treated and how they want their treatment to go. And so this brings me to our hive power. In the Faculty of Medicine, there are so many specialists. All of us have our different roles to play. We have allied healthcare professionals, we have all the different medical specialists, we have pharmacists, we have dietitians, we have dentists, and we are all a bee, okay? But if we all play a role, we can actually improve patient outcomes by improving the patient in a holistic manner. So I started my my project in osteoporosis, and on the left-hand side in black, that's all my fellow collab B raters, and these are all the projects that I've done in osteoporosis. So osteoporosis is a systemic skeletal disease characterized by lone bone mass and microarchitectural deterioration of bone tissue, making bones more fragile and more prone to fractures. Globally, about 20% and 20% of women and 11% of men have osteoporosis, and in Malaysia, the prevalence of osteoporosis in women more than 45 years is between 18 to 24%. Fragility fractures affects about 200 million people worldwide, and 8.9 million fractures occur a year due to osteoporosis. 1 in 3 women and 1 in 5 men more than 50 years are expected to suffer from osteoporosis. The consequences of insufficient population screening is there's missed early detection, there's increased fracture risk, and the public will not be aware of osteoporosis as a critical health issue. The good news is that it is cost-effective to treat those with high fracture risk, and non-pharmacological interventions includes weight-bearing exercise, fall prevention, a high calcium diet, sunlight exposure, and vitamin D supplementation. And there are anti-osteoporosis medications, and all these reduce the risk of hip fracture by 30 to 45%. We have done a number of studies, my team and I, which I will introduce my partners in crime later. In UMMC in 2017 and 2018, we found that in a retrospective data, when we looked through this data in the UMMC e-medical records, we found that over 1,000 female patients presented with 1,000 hip fractures. The quality of life of postmenopausal women suffering from osteoporosis was poor, and their knowledge regarding the risk factors for osteoporosis was low. So I then developed a pharmaceutical care plan for patients on how to take bisphosphonates in the correct manner and to persist with their therapy, and developed an interprofessional collaboration osteoporosis screening program utilizing the OSTA, where you just ask for the patient's age and weight, use the FRAX calculation tool that's specifically designed for Malaysian, Chinese, Indian, and Bumiputra, and this can calculate the 10-year probability of fracture with a bone mineral density that's measured by this machine, and we actually assess the feasibility of this interprofessional collaboration here in Malaysia. We then assess the effectiveness of this interprofessional collaboration program using the randomized controlled trial study design in Klinik Kesihatan Kuala Lumpur, where in the intervention arm, the pharmacist using the program that I described in the earlier slide to screen postmenopausal women, and if they were at medium or high risk, then the pharmacist would write a note on the medical folder to the doctor. This person is at high risk, recommended to send this person for bone mineral density screening, and most of the doctors followed it. And we found that in the intervention arm, 29.4% of women were diagnosed with osteoporosis, 33% with osteopenia. Osteopenia is between normal and osteoporosis, and 37% had normal BMD. And in the control arm, which was just standard care, no BMD scans were ordered. So the impact on clinical practice, I developed an osteoporosis booklet for patients in English, Malay, and Mandarin so that patients can now have the knowledge to modify their lifestyle and improve their bone health. Medications, which previously could only be prescribed by specialists, can now be prescribed by primary care doctors. And my team and I also set up the fracture liaison service in 2021. And I was honored to be one of the author of the clinical practice guidelines for osteoporosis. UMMC is now recognized as a fracture liaison, as a center with a fracture liaison service. And in the pipeline, we are going to perform a cost-effective analysis of this service in UMMC. And these are my partners in crime, and some of them are actually sitting in the audience today. Advanced care planning is the other, I apologize for the slides. Advanced care planning is the other area that I've done quite a bit of work in. And these are my past publications. So the key focus of the RMK 12 and the health white paper endorsed by Parliament in 2023 moved from sick care to primary health care, leverages on digital health innovations, giving individuals and patients more autonomy over healthcare and well-being. So as Malaysian population ages, the need for quality end-of-life care in Malaysia is projected to increase exponentially by 2030. Within this context, the provision of quality end-of-life care is complicated when an individual's or patient's preferences are known. Challenging situations that arise include decision-making to continue or withhold treatments when family members and healthcare providers are unable to agree on a treatment plan, and continuing with futile treatments due to healthcare providers' fear of legal liability may be financially and emotionally draining for family members where resources are limited. So advanced care planning has been widely endorsed as a potential response to improve the quality of end-of-life care by encouraging patients and healthy individuals to express their preferences for end-of-life care when they are still capable. So our work on advanced care planning for the past 10 years found that only 3% of community-dwelling adults in Malaysia have heard about the term advanced care planning. But once it was explained to them, 85% were willing to engage in a discussion about advanced care planning. And we also performed a systematic review and found that knowledge regarding advanced care planning plays a crucial role in bridging gaps and building trust in ACP discussions. So the COVID-19 pandemic highlighted the importance and the role of digital health, including the use of mobile health apps for the future of public health. And My Sejahtera is an important case. So a mobile health would therefore be an important resource to enhance an individual's or patient's experience to promote the uptake of advanced care planning. And in Malaysia, the hospital in Sabah actually practices advanced care planning. They get their patients to actually sign 5 copies of their advanced directive. They give the patients 2 copies, and the other remaining 3 copies they actually keep in a medical folder. But the physicians down there say that when it comes to the point when they need a decision from the patient and the patient can't say anymore and they know that it's in the medical folder, it is really difficult to actually retrieve it, especially when the folder is that thick. So a mobile app could actually then be a resource for the person to actually obtain knowledge, contemplate options, and act on the decision and document this decision. So the impact to public health will be My ACP will be a game changer in future-proofing Malaysia's public health efforts. It will respond to the critical future needs and aspirations outlined in the Health White Paper. It aligns with the Ministry of Health's agenda of promoting the uptake of ACP among the people in Malaysia. It will help inform policy decision-making on the implementation of ACP, and it may reduce the barriers to ACP engagement among the healthcare professionals and the people of Malaysia. So this is in the pipeline. And my colleagues from Sunway University, who are also here in the audience today, we obtained the grant to develop the app. And the app is for everyone, but because Ministry of Health is our biggest health system end users, they will be the major end users, and we propose that it be the ACP app be copyrighted and jointly owned by Sunway University and Ministry of Health. And this is just a snapshot of our app, which has the 6 domains: what is ACP, my values, my options, how to start a conversation about ACP, my resources, and finally my decision. And this was our meeting with Perkembangan Perubatan in Putrajaya. I again was very honored to be part of the co-authors of the Malaysia's National Advanced Care Planning Guideline as well. So moving on to deprescribing. The prevalence of polypharmacy, defined as being on 5 or more medications, is pretty high in Malaysia, ranges from 45 to 80%, and a patient who has multiple chronic conditions and living in long-term care facilities has a higher chance of being on polypharmacy, and a poorly updated medical records and poor transition of care between home, primary care, and the hospital predisposes a person to polypharmacy. And the consequences of polypharmacy are as shown on this slide. So deprescribing is a process of withdrawal of an inappropriate medication supervised by a healthcare professional, and it is used to improve patient outcomes and decrease risk associated with polypharmacy in older people. The benefits are to reduce medications that are no longer required. It can reduce adverse drug reactions, false risks, and improve cognitive function, and improve the quality use of medications and reduce the risk of medication-related harm. Deprescribing can be done in any of these populations, and my work has predominantly been in older people and patients at end of life. How do we do deprescribing? Is to review all current medications the patient's on, to identify potentially inappropriate medications, to assess the risks and benefits of continued use, to monitor and support the patient throughout the withdrawal process, and to involve the patient and caregivers in this process. When do we decide on when to deprescribe? When the medication has absolutely no benefit or when harm outweighs benefit. This is work in the pipeline. It is subject to the Pengarah of UMMC's approval, but we intend to set a new pharmacist clinical service in the specialist clinic in Ruka, and this is a collaboration between the Faculty of Medicine and the Faculty of Pharmacy. And our objectives are to deprescribe medicines whenever we can and to reduce the risk associated with medication use. Move on to antimicrobial stewardship. Being a pharmacist, antibiotics and antimicrobial stewardship is a subject that is passionate to my heart as well. And so we did a study, Prof. Sashila, with Mankit, okay? Was antibiotics in surgical ward a use or a misuse? So we did a prospective study in 2012 to 2013. We compared it to the compliance, whether it was in compliance to the Malaysian National Antibiotic Guideline or the International Clinical Practice Guidelines as determined by an expert panel that consists of 2 ID physicians and a pharmacist. We found that 26% of patients received appropriate antibiotic therapy, 73% received at least one course of inappropriate antibiotic therapy, and the prevalence of inappropriate antibiotic use was higher when the antibiotics was used prophylactically, which means to prevent an infection, rather as compared to 42% when the antibiotic was used to treat the infection. We also did a retrospective study of all the medical records of adults with suspected UTI that came in 2016 in Ruka. Antibiotics were prescribed in 83 consultations. We found that 74% of antibiotics were prescribed appropriately. That's pretty good for Ruka. Kudos to the doctors in Ruka. Only 20% were inappropriate, and 2% could not be determined. We also did a hospital-wide point prevalence survey, and this was a huge task. We did it in 2 hospitals, UMMC and HCTM. Data was collected from patients' medical records. It was recorded using NAPS, which was a survey toolkit developed by Australia. And in medical patients, we found the appropriateness of prescription was 60% in our hospital and 67% in HCTM. No difference between the 2 hospitals. And compliance with guidelines was about 60% for both hospitals. And in surgical patients, because UMMC had electronic medical records, we had better documentation practice, and guidelines compliance between the 2 hospitals were not significant. With Dr. Helmi, Prof. Helmi, we actually looked at how medical students use their white coats, because white coats can be a reservoir for bacteria, and medical students we didn't know whether they knew how to take care of their white coats. So we administered a validated online survey and we disseminated it to 670 students from 4 Malaysian medical schools via random sampling. 50% of medical students did not like their white coats because it's too hot. Most students correctly answered the role of white coats and in infection transmission, but they performed poorly on the effect of ironing on pathogen removal and the ability of A. baumannii to resist antibiotics. And most students, luckily, did not share their white coats with others and would remove their white coats when going to the toilet, exiting from laboratories and clinical areas, or eating in restaurants. And perhaps that's why you see the shift today that we don't wear white coats to the ward anymore, because of the transmission of bacteria. And part of the fun of this is that we also organize Antibiotic Awareness Week, and these are just some of the photos from the events. The other area that I've actually done, this is more the fun part of it now, is the safe disposal of unused medicines, because if medicines are actually disposed of into the environment in an unsafe manner, it can leak into the water that we drink, and it can give rise to antimicrobial resistance. So this is our team, which includes Puan Zhu, Prof. Deborah, Mary, Dr. Tan Kitman, and these are the Pengarah and Deputy Pengarah Puan Zhu at that point of time, when we actually launched this in UMMC, where patients can actually return their unused medicines to our outpatient pharmacy. We then also collaborated with Caring Pharmacy. And this also then gave rise that I was actually a mentor to a group of very energetic young people from the Faculty of Science. They organized this event called Pills to Art, where it was youth leading change, not old folks like us, united for antimicrobial stewardship. So this was really, really awesome. And the aim was to raise public awareness on the proper disposal of medications and antimicrobial resistance. So they had a safe disposal. They had even the pill art exhibition to create educational and awareness-focused art. And they even had really nice, fun things like batik painting and coloring contests. And these were the bins that they provided. And this was the Pills to Art. These art were actually created from expired pills. And this is the long love-hate relationship between human and bacteria. Nice one. And a Pills to Art and a Goose Hong meme. And it's really also important to engage the community in research. And one of my projects currently is to empower community leaders, particularly in the rural areas, to empower them and teach them how to screen BP and to educate the people around them. So hypertension is one of the main risk factors for stroke and ischemic heart disease, and the prevalence of hypertension in Malaysia is high, 20 to 30%, and about 50 to 65% are not even aware of their hypertensive status. So rural patients act differently from urban patients. They have different challenges in coming to the clinic. So we intend to actually have screening programs, empower community leaders, teach them how to screen and to have these knowledge transfer programs within the rural community. And this is our visit to Hulu Langat Batu 14 Health Clinic. Most of my work has been with older people, and I have met some really healthy older people, and they are my golfing buddies. My golfing buddies are in their late 70s and 80s, and they can walk 18 holes 3 times a week under the hot blooming sun. And you know what? When I grow older, I want to be just like you. I have also been using teaching using interprofessional collaboration. One of them is using the jigsaw technique. The PILS team, which is the Prescribing Initiatives for Lifelong Learning Skills team, initiated the jigsaw learning technique in the prescribing workshops for final year medical students. It was initially led by Prof. Deborah and now being led by Dr. Elsa from pharmacology. What is the jigsaw technique? The black jigsaw puzzle represents the medical student. So the jigsaw groups are formed. Each student is assigned to learn an area. And so these are the 6 areas, like defining what the patient's problem is, selecting the personal drug, verifying the suitability of the P drug, and getting the sources of information, what drug reference, what is the cost of the drug, how to write the prescription, and dosage calculations. So these jigsaw puzzles, each medical student or pharmacy student would learn from the 6 expert groups. Then they will go back to their own group and they will teach their fellow colleagues, students, what they learned. And they are reassembled to discuss the cases. So our jigsaw technique was also published. And we then actually observed these final year pharmacy and medical students over 2 years and how they learned from each other as the expert and jigsaw group. We asked them to fill up the SAIL score, which is the student acceptance of interprofessional learning. And we found that medical students scored a higher satisfaction compared to pharmacy students. In our department, we have the final year medical students, and I teach them how to prescribe. And instead of doing it in the normal lecture way, I actually introduced a game called Jeopardy. It was actually Prof. Christina and myself. So she's my partner in crime in this. So final year medical students were divided into groups and were encouraged to compete on who could write the most accurate prescription in the shortest time. The group that won the most points at the end of the session won. And these are the 5 categories of where prescriptions are written for children, pregnant women, older people, those with acute or chronic illness, and of course the students who rated this activity highly and mentioned that they would really like to play this game in all the other the learning subjects as well. I'm also honored to head the department's research committee. We are a department of 22 academicians. 4 of us are non-family medicine specialists, but within the department research committee, there are about 6 family medicine specialists. The aim of our committee is to develop and implement a primary care research strategy, to conduct high quality and pragmatic primary care research, to collaborate with fellow researchers at faculty and national and international levels, to implement research evidence in clinical setting, and to increase primary care research capacity by training novice researchers and PhD and master's candidates. I am very proud to say that since 2010, we have 17 completed PhD, 11 completed masters, and our total are as shown on this slide here. We have also conducted and developed online workshops, Introduction to Research Healthcare, Introduction to Research for Healthcare Professionals, Manuscript Writing Easy, Made Easy, Quantitative Research, and a Clinical Audit workshop. And all these courses are online and they're conducted twice a year. We also conduct these workshops face-to-face, a qualitative workshop, the Mixed Methods Research Workshop, and the Systematic Review Workshop. As mentioned by Prof. Kahar just now, the UM&US Golf Tournament has been a big part of my life, and it's really, really nice when you can mix business with pleasure. And a bit of the history of the UM&US Golf Tournament. It began in 1968 because to foster a relationship between UM and NUS. It is hosted alternately by 2 universities to strengthen ties between the staff, alumni, and students. And our patron is actually the Chancellor of UM. So the Sultan of Perak is present, as well as the President of Singapore. And it is a big do. And it is a lovely, time-honored tradition that I've been part of since 2002. And somehow or other, I don't know how, and don't ask me to repeat this, since 2002, I've actually had the honor or the privilege to have won 5 trophies as Best Ladies Golfer. As I said, don't ask me to repeat it, okay? It's probably the temperature, the time of the day. And somehow or other, VC appointed me as vice captain of the UM team this year, so I don't know how that happened too, but that's how it is. So activities outside of UM, I'm a member of the International Pharmaceutical Federation Technology Advisory Group and invited to give a talk in Indonesia as well as in Sri Lanka. and co-chairperson of the Malaysian Pharmacists Technology, Devices and Innovation chapter, and was invited to the National Pharmacists Convention in 2024, and also a speaker for the Malaysian Osteoporosis Society. So as healthcare challenges grow increasingly complex, no single discipline can address all aspects of a patient's needs. The Power Hive represents a dynamic and integrated approach where clinicians, healthcare professionals, community can work together seamlessly to share knowledge and co-create solutions and support one another. This collaborative model is the way of the future in healthcare, where unity, synergy, and shared purpose redefine excellence in primary outcomes. I would like to invite my son, Brian, and his music teacher, Ross, to the stage. They are going to be performing codex. You all saw the piano and you thought I was going to play, right? No way. It was already stressful enough to prepare for this event with all the slides and all. So Brian and Ross would be performing on the codex, which incidentally means it is a book of reference, a medicinal reference for pharmacists. And I think the senior pharmacists here would recognize this book here. So without much ado, I'll get the back people to put on the montage. Wasn't that awesome? And to my fellow audience, those present here physically as well as online, you are my power hive. The reason I'm up here today is because of you. Thank you for being here today.
Thank you very much, Prof. Pauline, for your truly inspiring lecture. I would now like to invite Yang Berusaha, Professor Engineer Dr. Kaharudin Dimyati, back to the podium to summarize and conclude today's inaugural lecture.
Wow. Thank you very much, Prof, for the enlightening inaugural lecture. Again, we have a piano today. Yeah, that is what I was told by Dato' Yang. That is how basically medicine should do for their inaugural lecture. When I first chair, the first was Prof. Ong last time. Okay, and then Prof. Lupa nama siapa? Huh? Yeah, Prof. Kartini. We have Suhaimi Mio Hassan. And now we have piano. Huh? So I really thought actually Prof. Pauline just now. When I saw the piano just now, I asked Prof. But she said her son will do it. Okay, ladies and gentlemen, thank you once again, okay, Prof. Pauline, for the truly engaging and thought-provoking inaugural lecture. Yeah, through the lens of the beehive, you have shown us the beauty and power of interprofessional collaborations. Yeah? So I think we can see just now, yeah, from the slides, from the collaborations that she engaged or she has for the past, I think started from her career as a pharmacist back in early 1990s. Yeah, right up to 2010 when he became a lecturer and now a professor. I think there are a lot of collaborations, and that is basically the power that she wanted to show today, the power of beehive, or how basically individuals with distinct roles, when united by a shared purpose, can build something far, far greater than what any one of them could do alone. Yeah? Your research, Prof, and experience have made it clear to care for our elderly populations effectively, we must work together, doctors, pharmacists, nurses, dietitians, and many more, yeah? Not working in silos, but as one cohesive and compassionate unit. You have not only highlighted key areas such as osteoporosis, the deprescribing, advanced care planning, and community engagement, but you have also reminded us of the importance of humility, mutual respect, and a commitment to a greater good. On behalf of all of us, I thank you for your dedications, your wisdom, your continuous efforts to improve healthcare, not just through systems and science, but through people and partnerships. Congratulations, Prof. Congratulations again on reaching this important milestone, and may your hive continue to grow and inspire. So with that, thank you very much, and back to MC.
Thank you, Professor Kaharudin, for chairing this lecture today. And thank you, Professor Pauline, for your truly impressive and heartwarming lecture. In harmony, the bees convene, a buzzing family strong and keen. Together they weave their golden thread in the hive's heart where dreams are bred. Ladies and gentlemen, this concludes our event for today. Thank you very much for sharing this momentous day with Professor Dr. Siew Pauline. So to commemorate today's event, photography sessions will commence right away. And I would like to start off by inviting Prof. Kaharuddin and the Queen Bee of the Hour, Prof. Pauline, for the honeybee, for the first photograph. All right, and now can we all together take a group photo? Those of you who are seated at the back, would you mind coming closer to the front and we can all huddle together? Yeah. And those at the back, please stand, yeah, so that you can be seen in the picture. Be moved to the center. Okay, I'd like to invite everyone for some refreshments outside at the foyer of the hall. Thank you very much, everyone.
Here? Okay. Yeah, I heard. I heard you're going for the same meeting.